Today we are going to study an important topic. It's flow cytometry. It's an important technique that pathologists should be aware of. It's more of a postgraduate topic. I don't think undergraduates will understand it much, but I've tried to explain it simply, but it goes on very sort of beyond the scope of undergraduate pathology. So whenever we see leukemia on blood smears, we are confused whether it is myeloid or lymphoid. We cannot give it on a confirmative basis. We can see, for example, in this, we can see blasts and we can see nuclei in a few, and we can say that myeloblasts and lymphoblasts are somewhat different. For example, myeloblasts have more cytoplasm, more nuclei, have all rods, and etc. The chromatin differences are also there. But to say that on a confirmatory basis that this is the diagnosis, and then to assign the lineage, because we know that there's a whole WHO classification for AML and ALLs. So flow cytometry is a laser based technology which is able to identify and quantify cell populations. Cells in suspension are manipulated into a stream of fluid where single cells are interrogated by an electronic detection system that we'll see. It has many applications and is now routinely used in the diagnosis of hematological malignancies. So it has 5 main components. So we have, this is the laser, the green color is the laser, and this is the flow cell within which every single is flowing every single cell is flowing individually, and that is interrogated by the laser, and then these cells will emit either forward scatter or side scatter, and can also emit fluorescence if we have added some fluorescent labeled antibody to the original sample. So we have lasers which provide the monochromatic light. We have the flow cells within which there is a liquid stream which will align the cells individually. And then we have optical systems and filters which regulate these light signals. And then we have detectors which will detect the forward scatter or the side scatter or the fluorescent signals. And then of course the computer will analyze these signals. So we'll see how do you prepare a single cell suspension. But we prepare this single cell suspension, we inject into this fluid stream, and it passes through this capillary tube at a constant velocity. This sheath fluid serves to maintain the particles in the center of the flowing stream, where they are illuminated by one or more focused light sources, which we usually use lasers. So if there is forward scatter light emitted from the cell, it is telling us about the size and shape of the cells, which is the cross-sectional area of the cell. If the cell is emitting, or the particle is emitting side scatter, it tells us about the complexity or the granularity of the cell. But these are intrinsic features of the cell. Sometimes we need to know more about the cells because there are many other, for example, there are surface receptors, there are antibodies produced by the cells, and there are intracellular antigens also. So if we label these antigens or receptors or these antibodies with fluorescent molecules or fluorochromes or fluorophores, which we'll also discuss the type of fluorescent fluorochromes, then our cells will, because of these fluorochromes, when excited by a typical excited by the light of wavelength of the typical excitation range, they will also emit fluorescent signal, which can also be detected by our filters. So hence flow cytometry will be giving us a multi-parametric analysis of each cell. So the number of parameters you can see depends on the number of fluorescent molecules. Sometimes people even use 17 to 18 fluorescent molecules. So the more number of parameters you want to see, the complexity of the design, and of course the number of fluorescent molecules you've attached will be increasing. Now the principle is fluorescence is one of the most common ways to study the cellular characteristics using flow cytometry. So what do? You add labeled antibodies to the fluorescent labeled antibodies to the cell sample. These will bind to those specific molecules on the cell surface or inside of the cells. And so when laser light of the right wavelength will strike these fluorochromes, a fluorescent signal will be emitted, which will be detected by our flow cytometer. Now the types of plot that can be formed are histogram, dot plot, contour plot, and density plots. So this is, first one is the contour plot, and then we have the grayscale density, and then we have the density plot and the dot plot. So dot plots are commonly used, but density plots are the most accurate ones. Firstly, because they give information about each and every cell at every frequency, at every level, and also they give like density in, like they give sparsely populated area or densely populated areas. They also are able to differentiate between them. So density plots are considered to be the most accurate ones. Now, how do you prepare the sample? Any specimen from which a single cell suspension can be generated is suitable. So, of course, your blood, your bone marrow, your CSF fluids, or even your FNA. So, peripheral blood, bone marrow, lymph node, CSF, ascitic fluid, and your aspiration cytologies. Blood and marrow can be anticoagulated. You can use heparin or EDTA or ACD, but most commonly heparin is used. And then if you want to transport or store the tissue specimen, you can use cultured medias like RPMI 1640. How do you generate single cell suspension? There's two steps. First, you will mechanically disaggregate the sample, and then you will do filtration. So mechanically, you can disaggregate by scalpels and forceps syringes or needles and meshes, and then you'll filter the specimen sample by fire gauze mesh to remove the aggregates. All of these specimens can be stored at room temperature before preparation, but if you think that preparation is delayed, you can refrigerate because that will retard the degradation. If you are analyzing only WBCs, you need to remove erythrocytes. So the most commonly used agent is ammonium chloride. So what is the method? This is a very simplified method, because if we were to refer to certain books like DESI, for example, it gives the preparation method, the specimen, the whole procedure for flow cytometry, it gives it differently for intracellular antigen or for membranous antigen or for the antibodies produced. It gives different steps. But in brief, in simplification of this method is very in 3 steps. That is, you add the antibodies to that representative blood or marrow. You add the antibodies, then you do the RBC lysis, then you wash it with a phosphate based buffered salt solution. To fix the specimen, to fix the sample, or to fix the antibody binding to stabilize that, you can use formaldehyde also, 0.25% to 5%. You can use it with the lysing agent or after washing. So extra washing step have to be added if you have to remove the plasma immunoglobulin level. If you are going to analyze light chain expression of the B cells, you have to remove the antibodies which are present in the blood already. So you add extra washing steps for that. And once prepared, you have to put the sample as soon as possible on the machine. But again, fixation and refrigeration will delay the degradation if you need some time. Now, if you look at this graph, on the x-axis is forward scatter, which indicates size, as we talked about earlier, and on y-axis we have side scatter, which is indicating granularity. So how are we going to read any plot? Is that we divide this plot. The machine itself actually divides the plot into 4 quadrants. So an imaginary line is drawn from x-axis. Imaginary line is drawn from x-axis. And there is a common point of origin. So an imaginary line is drawn joining it on the x-axis, and it is extrapolated. Similarly for y-axis and extrapolated. How do you decide this common point of origin? Varies from machine to machine, and it's sort of very technical aspect which is beyond the scope of basic pathology. Now in this chamber, the x-axis, any reading which is to the left of this, if you are just seizing the x-axis, will be considered positive, and to the left would be considered negative. And any reading above this would be considered positive if for y-axis, and below this would be considered negative. So if in this we have 4 chambers now, so in this both the x and y are negative. In this we have only y positive. We have both x and y positive, and only x positive, y is negative. So if we are seeing at platelet, debris and red cell, they have no size. The size is very small, and so they are here, and similarly they have no granules also, so they are on this quadrant. Eosinophils and neutrophils, the granulocytes, among our WBCs, they have the size also big. They have big size also, as well as the granularity. So they are in the column where both x, they are in that quadrant of the plot where both x and y are positive. In this we see only forward scatter is seen. So we are not, because monocytes or lymphocytes, they do not have any granularity, so only they are here in this plot where only x is positive, that is only side scatter is positive. So monocytes are the largest, and then large lymphocyte and small lymphocyte. I hope I was able to explain clearly how to read the plot. Okay, now indications. So there can be neoplastic hematological malignancies, neoplastic hematological indications and non-neoplastic. So first is among neoplasms, we have diagnosis and the classification of those neoplasms. then assessment of biological parameters which are associated with the prognosis, and the detection of antigens which are used as therapeutic targets, and the detection of residual neoplastic cells after therapy. Among non-neoplastic, the classic disorder which is used for which flow cytometry is used is paroxysmal nocturnal hemoglobinuria. We'll see in later slides, and monitoring of HIV using CD4 positive T cell counts. Now, to understand what is the pattern of abnormal antigen expression in variety of leukemias, we have to first understand the normal patterns of antigen expression. So, first of all, B cell differentiation, I will be going marker wise. So, CD45 are in all the cells, and all the B cells from immature to mature ones. TDT and 34 are immaturity markers, so they are only seen in the immature ones. They are immaturity markers, so they are only in the immature cells. CD10 is in the early ones but also in the follicular center. CD10 is considered to be the follicle center marker. CD30 is almost everywhere, but the highest is in the plasma cells. CD19 and HLA-DR, if you see, it is in all the cells. CD20, it's in the late immature ones maximum and also in the follicular center, and CD22 almost all the cells but not in plasma cells, and immunoglobulins only in the mature forms and not in plasma cells normally. Now coming to T cell differentiation. Similarly, CD45 is in all from immatures to mature ones. CD45 in all. CD34 is a marker of immaturity. TDT again marker of immaturity, also in common thymocyte. CD7 and 2 almost in all. CD5 not in the prothymocyte but in late immatures and mature. Cytoplasmic CD3 in somewhat in immature but also in mature, but see the surface CD3 is only in the mature forms. 4 and 8 from common thymocyte, that's why it's called common thymocyte, because it is 4 and 8 positive, and mature and thymocyte and mature T cell, and T cell receptor in mature thymocyte and T cells. Similarly, neutrophilic differentiation we have. Now coming to monocytic differentiation. CD45 in all, CD34 maturity, CD13 blast and monocyte, and CD33 HLA-DR in all, CD64 and CD36 and CD16 are quite specific, but CD64 and CD36 are in the pro-monocyte and monocyte but not in the mature ones. And CD64 is here also in the pro-myelocyte, but they are not in the neutrophils. They are in myelocyte and monocytes as well, but not in neutrophils. Just wanted to make one difference. And erythroid 45-34 not seen in the mature RBCs or even in the retic. HLA-DR also not seen. CD117 again not seen in the later stages. 235 is seen in the later stages. Now the abnormal patterns of antigen expression. So normal hematopoietic cells are characterized by a reproducible gain or loss of antigen expression as they mature, as we saw that as the cells are maturing, either they are gaining some antigens or they are losing some antigens. Most hematopoietic neoplasms also have an abnormal immunophenotype which is characteristic enough to allow for the detection. So how are these neoplastics showing antigen expression? There are various ways in antigen expression is altered. So gain of antigens which is not normally expressed, abnormally increased or decreased levels of expression, asynchronous antigen expression, and abnormally homogeneous expression in a population which is usually heterogeneous expression. Now, for acute leukemia diagnosis and classification, how is flow cytometry helping? It identifies the expanded progenitors, that is a blasts, and allow for the diagnosis. It assigns lineage and hence gives us a classification also. It correlates with the normal maturational stage. So, progenitor population, we do CD45 and side scatter. For other markers of immaturity like CD34, 117, 133, 99 and TDT. Overall pattern of antigen expression allows the determination of lineage because expression of any single antigen is not used because there is a lack of lineage specificity for many antigens. For more closely an antigen is expressed to the level commonly seen in cells of that lineage, the more likely it accurately reflects the lineage differentiation. So this is blast gating has been done here. Blast gating is that we see we know on CD45 and side scatter most of the cells are, all of our cells we know where they are going to be placed, but we are doing CD45 and blast gating to be able to see the new, when we make a graph we know that the blast are also on CD45 and side scatter where there normally should not be any cells. So these are on, this is side scatter, granularity and 45. So granularity, so this is that these are the neutrophils, and so 45 these are our monocytes, and these are our erythrocytes, and again these are our B cells. These are B cells, these are lymphocytes, and these are our blasts. Acute myeloid leukemias, for more than 20% blasts either blood marrow or bone marrow, blood or bone marrow, sorry. Caution is advised when utilizing flow cytometric blast percentages to make an initial diagnosis, because there are some limitations of flow cytometry, but if one considers these limitations you will always be able to make an accurate diagnosis. So first, there can be an artifactual decrease of the actual population, because for example when you're using a bone marrow specimen, a bone marrow sample, it can have dilution by blood, so the blast will blast as much as so there is an artifactual decrease as compared to what would have been without the blood. An artifactual increase because you are lysing the RBCs. So it's only, so for example if you were giving ME ratio for bone marrow and you've lysed the RBCs, so we know that the blast percentages can be inaccurately increased, artifactually increased. Secondly, there is no perfect concordance between what you see on PBS and flow cytometry. It isn't that the direct correspondence is occurring like these many percentages seen on PBS, and so that exactly is the flow cytometry. But if you keep these limitations in mind, flow cytometry can still accurately diagnose our leukemias. Okay, so lineage assignment in acute leukemias. So for myeloid we have cytoplasmic MPO. For myeloid lineage we have cytoplasmic MPO, CD117, CD13 and 33. For ALL, which can be, so these are myeloid lineage, and then we have lymphoid, which can be BALL or TLL. For B we have CD90 9A, 22, 19, 10, TDT. And for T we have surface and cytoplasmic CD3, T cell receptors, bright CD7, here 10 was bright, and CD5 and CD2. So these are markers which we have already discussed also. So when you use flow cytometry for diagnosis of the acute leukemia, there is a diagnostic algorithm that you can follow. So first is you demonstrate that the blast has increased. So you do the blast gating. So you defined blast gate you use with CD45 versus side scatter, and you apply markers of immaturity to see that this is in fact a blast population. We have confirmed the blast population, but we are demonstrating that this is an immature population. You use specific markers of the blasts only. Then you want to see the lineage. So for example myeloid we have CD13, 15, 33, CD117 and MPO. For monocytic we have 14 and 64 are classic but also CD33. B cell 19, 20, 10, 22 and 79A. T cell 2, 3, 4, 5, 7, 8, 56, and others are CD38, HLA, D123. So lineage assignment is determined by a combination of antigen, not by expression of one specific. Antigen expression near levels of the normal counterpart is more likely lineage specific. Aberrant expression is also very common. Initial parallel allows for the lineage assessment. So for B lineage you can BLL you can do easily. For T lineage you can do TLL wale markers. You have to rule the early thymocytic precursor T cell leukemias. And for myeloid and monocyte you can say that they are AML, but you have to use APML and you have to use plasmacytoid dendritic cell neoplasms by using these markers. And so for some entities you cannot allow, some entities do not. So for some entities, even if you use the initial panel, it would not still allow for lineage assignment. So M6 and M7 are one of those. So for biphenotypic allelic, so you use some markers for that, CD235A for example. And for M7 undifferentiated AL also, it does not have any adequate expression of any typical markers that you can say that they will give the lineage assessment. So this is the precursor lymphoblastic leukemia. So we know CD45 and side scatter is showing gating, blast defined gating we are using. For on the second graph we can see CD19 is dim expression, CD20 is negative. Bright expression of CD10, that means it is B cell. This is a blast and this is B cell. And again CD33 is positive HLA-DR. So here CD33 positivity and CD13, it might seem like it is myeloid because these are myeloid markers, but sometimes there is aberrant in ALL. there is aberrant expression of myeloid markers, which is frequently seen. It does not suggest that it is myeloid differentiation. It is aberrantly seen. And the cells have low side scatter also. And CD34 blasts, so they are positive, and some population has CD34 and 38 both positive as well. The next entity we have is EML with differentiation. So we have the blast gating, then we have HLA, DR, FITC. So fluorochromes, remember we talked about the fluorochromes we add. So fluorochrome level antibodies. So FITC is a fluorescent isothiocyanate and P is phytoerythroidine. These are the fluorochromes that we use to attach the antigens on the cell. So cell surface has CD33 or HLA, DR is also present on the surface. So these antibodies, they attach to it. So coming to this reading of AML with differentiation, so CD33 is positive, which indicates a myeloid population, and HLA-DR is positive. 15 is negative. 15 is positive, but 11B is negative. 11B is a neutrophilic marker. CD13 is showing bright expression, again myeloid lineage. CD16 is negative. 34 and 38 both are positive. 117 again myeloid marker. So 13 and 33 in the previous one were not giving. Maybe confusing us with myeloid differentiation in leukemia, but it was not. It was a lymphoid differentiation. It was ALL, which was showing aberrant expression, which is seen. So when you see 117 also, that is saying that it is definitely AML, but just with differentiation. Next entity we have is APML. So here you see the side scatter has increased. So that means there is more granularity in this, whatever these cells are. CD33 is positive, HLA-DR is population, but only few. But CD33 is positive, so it is quite intermediate to bright positivity. So it is some myeloid origin, neoplasm. 11B is positive, but 15 is negative. Only some population is showing 15 though. CD13 positive. And then here we have CD38 positivity, 34 is not positive, so it's not having blasts. And then CD7, 117, and this is lacking the expression of CD34. So CD34 is negative, and HLA-DR is also negative, and high side scatter, and but CD117 is seen. That might be indicating normal promyelocyte. So the problem is there significant lack of expression of CD15, which is characteristic for promyelocytic leukemia. So this is characteristic and common abnormality in promyelocytic. So this is APML. Now again coming to the next entity. Just a second. This is acute myelomonocytic leukemia. And now coming to this was diagnosis and classification, but we also have prognostic factors. But the thing is, if you've already done your cytogenetic or molecular abnormalities have already been established, then flow cytometry has no longer any prognostic role. But otherwise, yes, the recurrent cytological or cytogenetic or molecular abnormalities are an important prognostic feature. Therapeutic target for AML, CD33 is the most commonly used therapeutic target for in flow cytometry, and it is the target of anti-CD33. So when you want to give patient, you want to put patient on gemtuzumab or ozagamicin. ALL, so targeted monoclonal antibodies can be used, or T cells can be used, and some B cell targets. So B cell targets can also be used, like 19, 20 and 22. Now so residual disease monitoring. So whenever the patient is presenting, when you take that sample and you diagnose the disease, that immunophenotype will be changing after you've treated the patient and there is something still persistent, the recurrent disease or the recurrent disease. So more than one antigenic pattern has to be monitored. So do not expect exactly the same immunophenotype seen at diagnosis to persist after therapy. And why this is important is because this has the risk. This demonstrates the risk for relapse in overall survival for both AML and ALL. So that's why residual disease monitoring is important. Now coming to lymphomas, for again diagnosis and classification of lymphomas, identification of an expanded population of abnormal mature lymphocytes, and most common method is you use the light chain restriction in B cell proliferation. Now when we use the term light chain restriction, it doesn't mean that this population has decreased. It means that only this population is seen, because we have most commonly immunoglobulins produce lambda and kappa genes. So when you say lambda chain restriction, it means only lambda chain is being produced in this particular B cell neoplasm. Neoplastic lymphocytes arise from a single precursor that undergoes clonal expansion. So this is clonality. We'll discuss it. Each lymphocyte normally expresses one of a series of polymorphic molecules on its surface that provides unique identity. So we need antigenic expression. So B cells, so we have to establish the clonality of those cells, of the neoplastic cells, and we also have to establish the antigenic expression like the cluster differentiation markers. So for B cells, immunoglobulins are the most common, and immunoglobulins have kappa or lambda chains. So reagents which are directed against these light chains can be used as markers of clonality for B cells. T cell receptor genetic locus is a little bit complicated, so it has alpha beta chains. So you can use reagents against the beta chains of the T cell receptor to demonstrate clonality. And for NK cell clonality, there is something called KIR inhibitory receptors, KIR antigens on the surface of NK cells, and we can use reagents against these. But again, clonality itself is not sufficient enough to say that it is a lymphoma. We need morphological and clinical context, of course, and we need alterations in antigen expression to provide the evidence of neoplasia. And specific alterations are seen in association with different categories of lymphomas. Alteration in the intensity of antigen expression is a very common abnormality in B cell neoplasms. B cell lymphomas. In B cell lymphomas, immunoglobulins can be increased, decreased, or even absent. Similarly, T cell lymphomas also show alteration in the expression of their antigens. So we combine the detection of clonality with the ability to identify alteration in the antigen intensity through flow cytometry. We'll see this how. So for small to intermediate cell lymphomas, you have to first confirm the B cell lineage, that is CD19, 20 or 79A, and you assess for the clonality. So you have to establish both. You have to establish the lineage as well as clonality of the cells, kappa, lambda, or surface immunoglobulin negative. After that, CD5 and T10 are two important markers to distinguish between lymphomas. Now why that is? Because CD5 is an aberrant expression. So we know that B cells do not show CD5 is a marker of T cells. So if CD5 is being positive in B cell neoplasms, it is an aberrant expression. So that's why CD5 is important, and it is seen classically in CLL as well as mantle cell lymphoma. So we perform additional markers like CD23, CD200, and FMC is negative, and the exact opposite panel is seen in mantle cell lymphoma. FMC positive, but 23 and 200 are negative. Now on flow cytometry, if you have clinical correlation and if you correlate with the sequelae, for example, CLL can transform into DLBCL Richter transformation. So if you can establish this panel along with clinical correlation like older males in CLL, you can say that you can diagnose CLL on flow cytometry. But for mantle cell lymphoma, you need cyclin D overexpression by IC or translocation 11-14 to confirm the diagnosis. Now we have CD10. So there are many follicular center. So CD10, as we remember, is a follicular center marker. So follicular lymphoma, DLBCL or Burkitt lymphoma. So these are, but we are only discussing small to intermediate size lymphomas here. If both of these are negative, marginal zonal lymphoplasmatic lymphoma have significant overlap between their morphology. So you have to differentiate between them. You have to do other investigations, and you have to rely on morphology, but morphology is overlapping. So you have to distinguish lab data, and you have to distinguish between clinical data to differentiate between these two. And then hairy cell leukemia, we have some specific markers: 11C, 25, 103, and 123. So flow cytometry does allow for definitive diagnosis. So BRAF, if it is positive, it is a good thing, but it is not needed for diagnosis. Flow cytometry can diagnose lymphomas, only two, CLL as well as hairy cell leukemia. Now, if you compare these, so this is CD5 positive, CD19. So this is a T cell marker, B cell marker. These are both positive. This is the neoplastic population. Both are positive, so we can't say is it a B cell or T cell. But in the next graph, we have lambda chain restriction. So that means it is a B cell neoplasm. Again, CD20, that means it is a B cell. But again, it is CD23 and 200, both are positive, though it could be, it is CLL. Then again, CD5 or CD19, both are positive. We don't know whether it is B cell, T cell, but we have lambda chain restriction, so it is established it is B cell. Again, CD20B. And then and for again CD23 and CD200 are both negative, so it is mantle cell lymphoma. So not just 23 and 200, if you see 20 also, so here it is bright expression of CD20, in mantle cell lymphoma, it is dim expression of CD20 in CLL. This is the same slide. So this is the immunophenotype for CLL. This is the immunophenotype for mantle cell lymphoma. Coming to the next entity, the hairy cell leukemia, as we already discussed. So we have done CD40 side scattered, CD19 is positive, lambda chain restriction is there, CD10 is negative, CD20 is positive, CD11C and 25 and 103. So this indicates hairy cell leukemia. So this is the immunophenotype for hairy cell leukemia. Now coming to follicular cell lymphoma. So here CD5 is negative, it's a B cell neoplasm. That means CD19 is somewhat positive, not that bright, dim positive, and that also in small population. Kappa chain restriction, so that is a B cell neoplasm. CD20 positive, CD10 also positive, but we have many CD10 positive lymphomas. This is more important, that CD10 positivity in BCL2 population which is positive. So this is important. So whenever BCL2 is positive, we know that 14 to 18 translocation which is characteristic of this BCL2 is present. So we know this is follicular lymphoma. This is the immunophenotype for follicular lymphoma. Now DLBCL. This is a comparison chart. This is for CLL. This is for DLBCL. So you see this is forward scatter. This is not side scatter anymore. We are discussing the size. So if you see the size of these cells, neoplastic cell as compared to the rest of the population, and size of these neoplastic cell, it's variable, right? So this is the for DLBCL, and then again 45 versus side scatter. There is it is overlapping granularity, but it is much less as compared to. It is much more in DLBCL as compared to CLL. One main is of the forward scatter. Now coming to T cell expression, T cell lymphomas and their expression. This is angioimmunoblastic T cell lymphoma. If you see here, this is the purple is the neoplastic. CD4 is positive, CD3 also, but mostly CD4. CD2 positivity, CD3, CD5 positivity, and CD4 and 10 both positive. So 10 is aberrantly expressed in these neoplastic cells. So this is the angioimmunoblastic T cell lymphoma immunotype. Again, adult T cell lymphoma. But problem with leukemia, this adult T cell leukemia lymphoma is that we need HTLV serology positivity. That would be needed for confirmation. We can use prognostic factors for lymphomas. We can use flow cytometry for prognostication in lymphomas also, but only for CLL, only two prognostic markers are established, that is CD38 and ZAP70, and that also we do not have a very strict criteria. The criteria are very arbitrary. For therapeutic targets, for anti-CD20, if you are using the anti-CD20 rituximab you want to give to the patient, you can use that. Or in refractory cases, if you want to use LMTuzumab which is anti-CD52, you can use that marker as well. Again, minimal disease, residual disease detection is very important. This is plasma cell neoplasm. 45 and 38 are positive. 45 is negative, 38 is positive. Kappa chain restriction 138, and aberrant expression of 56. It's an NK cell marker. This is the immunophenotype for plasma cell neoplasms. This is for myelodysplastic neoplasms. For myeloproliferative, it is not immunophenotype which you will rely on. And this is for paroxysmal nocturnal hemoglobinuria. Flow cytometry is the principal diagnostic method for it, and it has PIGA gene mutation is happening in this disease where GPI linked proteins are absent, and two of these, that is CD55 DAF or CD59 MERL, their deficiency has to be established on at least two lineages like RBC and WBCs. And we can use for granulocytes and monocyte one of these GPI linked reagent which is used is FLAIR, which is fluorescent labeled proaerolysine. So for combination for neutrophils we use FLAIR 24, 15 and 45. For monocyte we use 1464, which is characteristic, and we use FLAIR and we use 45. and for RBC we use 235 and 59. Thank you.